The broadcast is now starting. All attendees are in listen-only mode.
You who are on the road must have a code that you can live by. And so, become yourself, because the past is just a goodbye. Teach your children well, their father's hell did slowly go by, and feed them on your dreams. The one they picked, the one you know by. Don't you ever ask them why. If they told you, you would cry. So just look at them and sigh, and know they love you. That your elders grew by, and so please help them with your youth. They see the truth before they can die. Teach your parents well, their children's hell will slowly go by. Them on your dreams, the one they picked, the one you know by. Don't you ever ask them why. If they told you, you would cry. So just look at them and sigh, and know they love.
Good morning, buzzards. I wonder how many of you recognize that was Crosby, Stills, Nash & Young, one of the greatest groups of the 60s. And of course, Neil Young is still around. He's caused a lot of controversy lately with Joe Rogan. Maybe you heard of that thing. Anyway, as you can see, today is Thursday. It's March 10th. Just like it says on both of our lists here, 2022. And this is our 6th and final webinar on the gastrointestinal system. Now, we've covered everything, okay? We've gone ultimately from the beginning, from the mouth, the esophagus, to the stomach, small bowel, large bowel, appendix, peritoneum, liver, pancreas, everything you could think of. And we've showed you a lot of microscopic pictures along the way, diagnostic, classical features. But what we haven't done is actually gone to the real slides from the real patients, the real glass slides which I have here. So that's what we're going to do today. And I guess I should make some kind of announcement. Well, of course, there's no PowerPoints today, but there's an awful lot of slides, okay? And I only took about half of them, so I only chose the ones that were sort of diagnostic and best for teaching. I didn't really choose too many of the exotic cases because, you know, I'm not training you to be diagnostic pathologists. I'm training you to be rock solid, knowledgeable in pathology for whatever reason, and especially when you take your step 1 exam, of which they're not going to throw too many slides at you. That's probably why on the lab sessions, there's usually not as many students as on the PowerPoint sessions, because they think, I don't want to be a pathologist. I don't have to know those slides. Well, I think that even basic physicians should have a visual idea of what's going on the cellular level in their patients' bodies when they whip up that old prescription pad. So let's get going. We'll close the ugly guy over here, and we'll open up the slide box, and it's called GI Lab. And of course, we're going to do things a little bit differently. Of course, if you remember, we started with the esophagus. We went to the stomach. Now, here's alphabetically. We went to the small and large intestines. We went to the liver. We went to the pancreas. Now, usually, and what I have been doing so far in this course, when we have labs, and we have about 5 of them or so already, what we have done is actually give you a hint of what it is. So if I had ESOPHNL, you're probably thinking, well, that's a normal esophagus. But I also labeled the other ones as well. Well, I think you're at the point where once you recognize solidly the normal esophagus, I think you can get a feel for how it's not normal in some of these other cases. These are the diseases, the first 3 and the last one. So what we're going to do is not label them, but we will start out with the basics, and that's going to be right here. And this is going to be, maybe, I hope for you, maybe it's boring, because like in the GI tract, we always have 4 layers, all the way from the esophagus to the anus. We have an epithelial mucosa. Sometimes we have a little submucosal connective tissue, or what might be called lamina propria at some point. Then we have the submucosa, which is rich in connective tissue and blood vessels and fat. And here's even a couple little submucosal glands. Then usually, except for the appendix, of course, the thickest, strongest layer is a muscular layer. And very often that's divided into perhaps longitudinal and circular, or in the stomach there's an oblique layer as well. Finally, we have a little bit looser connective tissue on the outside of the tube, no matter what part of the tube we're in. If it's in the abdomen or intraperitoneal, there'll most likely be a little lining of serosa. But if it's not, like most of the esophagus and a lot of the colon, then you're just going to have what we might call connective tissue or adventitia. So this is your esophagus. Let's zoom in a little bit more and then move on, because if I told you how many slides we have today, you'll probably go home right now. Whoops, I'm sorry, you are at home. So here we go. Mostly the esophagus is non-keratinized stratified squamous epithelium. Then you have, in some cases, a little cluster of mucus glands to help lubricate that food. Maybe they're a little more common in the upper esophagus. Then you'll have basically smooth muscle layers, but in the upper esophagus, you might see some layers of a few little fibers of skeletal muscle from the pharyngeal constrictors. So here we go. Mucosa. I just drove down Mucosa Road. Now I'm winding down Submucosa Road. Then we're in Muscularis. Some people call it Muscularis propria. And finally, we're on Adventitial Highway. The same 4 layers we're going to see through the entire gastrointestinal system. I'm going to show you a little something that you might not have remembered, even if you took histology. Even the esophagus may have some submucosal glands. And of course, you know that a little bit of lubrication from the submucosal glands is really appreciated. Okay, so let's go into the diseased ones. And to tell you the truth, I forgot what they are, so I'm going to have to recognize them too. So we might as well start at the top. Well, the first thing you're going to say is, why in the hell is Dr. Minarsik showing us a stomach? We're supposed to be talking about esophagus. This can't be an esophagus. It has glandular or intestinalized type of slightly villous mucosa. Yeah, there's a lot of vessels and connective tissue in the submucosa. Then we have a muscular layer. Well, what if I promised you this was an esophagus. Why would an esophagus be lined by gastric or intestinal or columnar or goblet cell type of mucosa? Because this is the Barrett's esophagus. So you know it's most likely in the lower portions of the esophagus. And Barrett's esophagus, of course, again, is a columnar metaplasia in which the normal squamous mucosa is converted into a columnar mucus, intestinalized mucosa. And technically, even though you can have submucosal glands, the mucosa itself should always be squamous. Why? It's a metaplastic process to protect the esophagus from gastric acid, usually and almost always because of reflux. The Barrett's esophagus is not in itself precancerous, but when an adenocarcinoma arises in the esophagus, usually the lower esophagus, because that's where the Barrett's and that's where the acid and that's where the reflux is, it's almost always from a previously existing Barrett's esophagus, which may have been present for 20 years. So when I went to my GI guy a couple weeks ago, he says, "Do you have heartburn?" I says, "Hardly, never." He says, "Well, let me look at your esophagus anyway." Why was that? So he could make more money. That's why. I don't want you to be that kind of a doctor. Here's the next esophagus. I don't know what it is either, but we'll figure it out. Well, it looks like a normal esophagus. Okay, but why is it folded like this? And here's a little area where the mucosa looks like it's a little ulcerated or eroded. But you could see muscle. You could see submucosa. You could see mucosa, and you could see connective tissue. Well, what if I was to tell you that this was like a ballooning out of an esophagus, and it has all four layers of the esophageal wall: the mucosa, the submucosa, the muscularis, and the adventitial connective tissue? Then you say, well, it's probably a diverticulum. And you're absolutely right. So not only is this a true diverticulum because it has all four layers, but also looks like there's a little ulceration and inflammation in this pocket. This happens to be a Zenker's diverticulum, not terribly rare, and it's in the upper esophagus. And why does it poke posteriorly? I'll tell you why, because it can't poke anteriorly because your trachea is there, remember? Okay, next case. I hope I'm not going too fast. After I do these 4 quick cases, I'm going to ask you a question as to whether you think I'm going too fast or too slow. Here's another esophagus disease. I don't know what it is, but I hope to figure it out pretty soon. Oh, yeah. Well, I can tell you it's an esophagus because you see muscular layers, longitudinal and circular. The cells that look spindly in the smooth muscle layer are probably cut longitudinally. The cells that look, the nuclei that look round, like, oh, let's see, let's find some round ones. Some of these are round. These are probably ones that are cut transversely. That's simple geometry. That's not medicine or pathology. But why am I showing you this? What kind of disease is it? I don't know. In the submucosa, where the vessels are always the most prominent because they have to feed the mucosa, they're very, very big and very, very dilated. And perhaps even here, possibly the beginning of a rupture, I can't say. So what would you call an esophagus? And you can, of course, see the squamous mucosa here. I'm going to show this to you as well. And the squamous mucosa, non-keratinized classical esophagus. But why would you have massively dilated submucosal esophageal veins? Almost always for one reason: portal hypertension. Okay, this patient probably had cirrhosis, most common cause of esophageal varices. Of course, if these big, big vessels burst, and you can see how close they come to the lumen, that could be fatal. And that's the number one fear, the probably number one cause of sudden death with cirrhosis. Okay, last one is going to be the one on the bottom. And what is it? I don't know what it is. Well, on the left, you could see a squamous mucosa which matures. In other words, it goes from sort of columnar cells at the base and they flatten out. They don't keratinize. Oh, it looks like there's a little bit of chronic inflammatory stippling over here. But what about the parts of this squamous mucosa, which is the esophagus, on the right? It doesn't mature. And you're thinking, oh, and there's a lot more inflammation. So, maybe you're thinking possibly that this could be the development of cancer, and you're looking at atypical cells, irregular, and you and your buddies are talking about whether this is cancer or whether this is dysplasia. Well, what you're not realizing is that all of this material underneath it, deep within the wall of the esophagus, and even disrupting the smooth muscle cell layers, like you see here, is infiltrating squamous cell carcinoma. Do you see how some of them look like they're a little pearly arranged? This might be called a fairly well differentiated cancer. Okay, I hope that was easy, and we're done with esophagus of the 5 things we're going to deal with. And this is actually one of the shortest ones. Esophagus and pancreas will be short, stomach will be medium, and colon and liver, there's a zillion slides. So maybe I won't show all of them. Okay, I have to ask you a question. I know you don't like to be bugged, and I know you may not want to answer. And I have no idea how many of you are out there. I'm going to ask you a very simple question. And if I get no answers, I won't be surprised. Am I going too fast or too slow or just right? I'm hoping somebody's brave enough to answer in the question box, because I know there are a few of you out there. Okay, well, maybe we'll save that question for later because nobody's answering too quick. So let's go to the next organ down the road, and that's the stomach. And we only got a couple of stomachs. How do you like that? Well, the one at the bottom, I should have labeled, and I will right now. I should have labeled this one NL. And I will. Because this is the normal stomach. And you could see there's a lot of submucosa. You could see the mucosa. These mucosal cells are not arranged as villi or papilla. Rather than that, they're pits. And of course, you can start to see some of the muscle layers. Not all of them, but if you remember, in the stomach, you have an oblique, then you have a circular, then you have a longitudinal, okay? But there's a good amount of submucosa, and this is what you might call a rugae, which is a little prominence of submucosa and mucosa to increase surface area. But we don't know what part of the stomach we're in, do we? Well, what if we zoomed in here and I showed you some chief cells and parietal cells? Then you'd know you were in the body of the stomach, which of course has the greatest amount of chief cells and parietal cells. Almost the rest of the stomach, the proximal end and the distal end, are mostly mucus cells to neutralize this horrible destructive battery acid. So let's see if we could find some chief cells and parietal cells, because you know that the parietal cells look like little eggs. And certainly they do. Take a look at this, folks. How about if I convince you that that cell, those bright orange individual egg-looking cells, These are all parietal cells. And of course, even before you get to the surface, you have a lot of cells secreting mucus to protect. Look at this is a big cluster of parietal cells, ultimately making the acid and, of course, the intrinsic factor to absorb vitamin B12 or to couple with the vitamin B12. So let's take a look at this stomach one on the top, and we're going to say, oh, well, you certainly have a lot of muscle, don't you? I'm not too sure if I could quite identify the three different layers, but of course the most surface one of the muscle is the oblique, and then you have a longitudinal and transverse. And of course, the stomach is very thick, has a lot of muscle, so that's probably the longitudinal and transverse here. But look, the mucosa and the mucosa only, because once you get to this muscularis mucosa, this little punched out area stops. So this is an erosion simply of the mucosa. And of course, it's a source for bleeding. But remember, once erosions cross the muscularis mucosa and go into the submucosa, they could then become truly what you call ulcers. So are erosions perhaps the beginning of ulcers? Yes. Do erosions have to progress into ulcers? No. This could simply be an erosion due to a stomach tube being in there for a while and irritating the mucosa. Yeah, it could bleed, but it's not going to bleed probably as much as a regular ulcer, which of course perforates into this muscularis mucosa on top. So, gastric erosion, very, very, very common. And also notice, even though you look, these glands may seem a little bit regular, when you look at the big picture, of course, the mucosal glands here in the stomach, no matter where it is, are nicely arranged and orderly, and of course, they don't invade. Okay, let's try the next guy now. The next guy is B71. Stomach. And look, this looks like it's perhaps a squamous mucosa, and up here it looks like you have glands. But what you really see is a very, very thickened wall, a lot of fibrosis in the wall. This is a stomach that's been very thickened. And furthermore, look, these smooth muscle fibers have been disrupted. And there's a lot of these little chronic inflammatory foci within the wall, as well as around this blood vessel here. So let's try to figure out what's going on. How about if we start, perhaps here, just make a big little slice. Here we have glands of the stomach, and here we have a squamocolumnar junction. Could this be perhaps something that has occurred at the squamocolumnar junction, or could this be squamous metaplasia of the gastric mucosa, which of course doesn't really happen very much? So you're wondering what kind of inflammatory or neoplastic process this might be. And perhaps you're scratching your head and you're talking with your friends and you're saying, is just this a bad gastritis with fibrosis? But then you start to think logically and you say, hey, wait a minute. Let's look up here. You see that these glands are invading the smooth muscle fibers. And in addition, they're very, very, very atypical. So yeah, this is a gastric carcinoma. And the glands are fairly well differentiated, but I have a feeling as you go deeper, you may see that they're very more poorly differentiated. And why is that stomach wall so thick? Could this be the beginning of a linitis plastica? In other words, a diffuse, poorly differentiated gastric adenocarcinoma that involves the entire thickness? Yeah, this could be the beginning. But at least for now, let's be honest and say this is a adenocarcinoma. It's not well differentiated, but you could see a lot of atypia. Big atypical cells here, big dark irregular pleomorphic cells here. And of course, even if they weren't, if they invade these smooth muscle fibers, they got to be cancer, right? Okay, so much for stomach. Now let's go into a big portion. We've taken the two easy ones. We've taken esophagus, which we could delete. We've taken stomach, which we could delete. And you're thinking, oh my God, it's only not even 9:30 and we already took care of two of them. Well, there's a ton of slides for intestine and a ton of slides for liver. So how about if we do the next easy one, which is pancreas? Not really out of order, but let's take a look. Well, here's one called PANC-NL. And then there's only three slides with it. So let's look at the normal pancreas. Maybe we showed you a normal pancreas when we talked about diabetes too. I can't remember. But yeah, these are lobules. These are lobes. There's a big duct between the lobes. So you call that interlobular duct. And even though most of these glands or lobules are very blue, you can also see that some of them have these little light areas in them, like here and here and here and here and here and here and here. These are islets of Langerhans. Here's a couple of them over here. If you don't believe me, let's zoom in. And of course, if you have an experienced eye, you could pick them out right away. Yeah, there's an islet. And they don't have that classical acinar type structure. They just look like little balls of cells secreting various hormones. But then in this lobule and this group of acini, they look like they are really glandular exocrine cells. So the exocrine cells have their granules towards the lumen of the acinus, and the endocrine cells have their granules towards the base where the blood vessels or capillaries are. But we've already spent a lot of time talking about islets in the last block. So let's zip in on a normal group of acini over here. I don't know, are you happy with that? Yeah, there you go. Perfect, classic, small pancreatic acini. If you see a lighter cell near the lumen, that could be a centroacinar cell which secrete bicarbonate. If you notice, however, well, let's see if we could zip in a little bit more. If you notice, however, I don't know, how about if we go here? That the nuclei are at the base, and of course the cytoplasm converge towards the apex, towards the center of the acinus. And these are where the zymogen digestive granules are made. And then, of course, you have a whole family of intralobular ducts leading into the interlobular ducts, which, of course, this looks like it's a pretty big one. So let me make sure that's a duct and not a artery or a vein. So let's zip in on it a little bit more. And here we go. Oh, it's an artery, and there's a vein. I called it a duct. I was wrong. I'm glad we have a zoom, a high power. But let's see if we could find a big circle that perhaps has a epithelium in it. So we could call it an interlobular duct. There's another big artery. Okay, could this be part of a big branch of the splenic artery? There's a little nerve, there's a little nerve, there's a little nerve. You know what? I'm having a hard time finding a big duct. Here's a medium duct. This is perhaps going to be leading into a duct between the lobules, but right now this is technically an intralobular duct. Okay, another artery, another vein. And look at these beautiful islets over here. Here's 1, 2, 3, 4. You want to zip in on them just as long as we're in the neighborhood? Yeah, there you go. Alpha cells, beta cells. You can't tell the difference, delta cells. And of course, look how the nucleus is not so much towards the base. It's basically needs a lot of room to secrete the hormones. Towards the base of the cell, of course, is where the blood vessels are. You know, I'm going a little crazy here because I haven't found a classical big interlobular duct, and maybe there just aren't any in this one. But if we found the main pancreatic duct, I bet you'd be impressed. But these are all blood vessels. So let's move on. Normal pancreas. Now, the one on the top must be an abnormal pancreas. And what is it? Oh my God. You're probably saying, what is this piece of junk? The cells aren't even in focus. You got a lot of fat that looks like it's being digested. You got the pancreas itself that looks like it's being digested. This is autodigestion. Okay, this is acute pancreatitis when the pancreatic enzymes are released because of a variety of reasons. Okay, bile reflux, ischemia, trauma. And let's see if we could prove to you that the reason why this cell looks so crummy is that these cells are getting blurred because they're being digested like a piece of meat. Okay? And let's also see, even though it's acute, you expect a lot of hemorrhage, which of course we see here and perhaps here. But let's see if we can also find the classical cells of acute inflammation, which are neutrophils. Well, not so much by way of neutrophils, but look at, here's a gigantic blood vessel. Could that be perhaps the splenic artery? I don't know. Acute pancreatitis. The main feature is autodigestion. And if you remember, the other features we talk about are saponification, because the stearates are released to combine with sodium to form sodium stearate, which is soap. And of course, there may be calcifications also, because when the stearates combine with calcium, they are then insoluble. Classical autodigestion of acute pancreatitis. Let's take a look at the next one. And what do we have here? Well, do you recognize a pancreas again? You know, cluster of exocrine glands. Yeah, these look like pancreatic lobules. But look how the lobules here are disrupted. And what basically are they disrupted by? Well, they're disrupted by two things which are related to each other. Chronic inflammatory cells, which you see here, and a whopping amount of fibrosis. So let me ask you a question. Let's say that this pancreas, which we're going to call chronic pancreatitis, because the chief cells are chronic inflammatory cells, and there's a lot of fibrosis, which is characteristic of chronic inflammation. But let's say somebody decide to just stick a needle into this pancreas. So you have just like a little cylindrical needle biopsy, and you take a look at this cluster and you go, oh my God, are these little poorly differentiated glands invading the fibrous tissue? Or is just a whopping fibrotic chronic pancreas? It could be very, very difficult. And most pathologists know that when there's going to be a frozen section the next day scheduled on a needle biopsy for a patient with pancreas problems, they often lose sleep, because if they see something like this and they call it cancer, they're going to take out the whole pancreas and do a Whipple's and a lot of stuff with it, maybe even the spleen, and the patient's not going to have cancer, and he's going to be sued for millions of dollars. Of course, if he calls it chronic pancreatitis and they don't take out the pancreas, maybe it really was cancer, and the patient can then blame his death on lack of an early diagnosis. So these are the scariest types of frozen sections. Let's look at the last pancreas case. And I think I know what this one is, but I'm not sure. Yeah. What if you say, you know, I have a hard time recognizing this as pancreas because I don't really see too many blue clusters of acini and lobules. But let's take a look at this. And you could say, well, yeah, here's a couple of kind of funny glands here, but there's a lot of fibrosis around them. So you're thinking, well, is this chronic pancreatitis again? Well, technically it is. But look, what do you see here? And what do you see here? And we're going to move down and even see more. Here's a lobule, but what is this? Okay. Here's another lobule, but what is this and this? These are islets. What would cause another common cause for this chronic exocrine inflammation in the pancreas, especially in newborn? This is cystic fibrosis. Because if you remember when we talked about all the reasons why a pancreas might be inflamed, blockage of the ducts is almost a sure cause for chronic pancreatitis. And very, very often in cystic fibrosis, these little islets like here and here, and probably here, are spared. So what can we say is that this is a congenital and sort of common disease. It has a wide variety of severity and phenotypic expression. So this is cystic fibrosis, the congenital disease, and it's often called cystic fibrosis of the pancreas because the mucus that blocks the ducts cause a secondary backup and eventually chronic fibrotic inflammation. Okay, next one. As a matter of fact, we could probably say, yay, we're done with pancreas. And it's only 9:30. But I got news for you. The cells, or the slides, the glass slides that we have here in our lab for the intestine, there's a whole bunch of them. And there's a whole bunch of slides on liver because these are the most common areas that are biopsied and the most common areas that get general clinical symptomatic diseases. So my feeling is to probably, I don't know, let's see which one has more slides. The one that says intestine has only 15 slides. That's not bad. The one that says liver has 19 slides. So you know what? Here's what we'll do. Let's do the intestines and then take our break. And then in the second half, we'll only have 19 slides to do. And once again, probably not have to go the full 2 hours. And I hope not. But I'm not promising you anything. So look at this. Wow. Let's see if we just view it as something a little bigger. Those are your 15 slides. And look at one of them says normal. So let's look at colon normal. That's probably the most beautiful colon that you'll ever see. It looks like it's cut longitudinally. You can see a beautiful mucosa. And you know this is large bowel rather than small because you don't see villi, which are little papillary projections, but you see fits going into the crypts, okay? These little pits are called crypts. And then you could see malt or mucosal associated lymphoid tissue. Here's a cluster of a secondary follicle. Here's one, here's one. And it also looks like that these follicles, which some people may want to call Peyer's patches, but technically Peyer's patches were the property of just small bowel, but looks like they largely go both into the mucosa as well as reside perhaps largely in the submucosa as well. That doesn't mean they invade the muscularis mucosa. It just means that being very, very rich in this very vascular, loose connective tissue submucosa, they have to release their things like secretory IgA, of course, into the mucosa to help neutralize some of the bad things from the poop that may be on the other side. So here, let's do a quick trip through the 4 layers again. And this would probably be a good place to start. Here's the mucosa. Here's the gastric pits, also known as the crypts of Lieberkühn. Here is the muscularis mucosa. Do you see this nice little strip of muscle? Once you breach it, you are then in the submucosa, which may be a very, very wide layer because it has a lot of loose connective tissue and big blood vessels. And most of the malls are secondary lymphoid or primary lymphoid follicles, like you see here, without a germinal center. And these that have the germinal center, which are called secondary follicles, they reside mostly in here, loose connective tissue. And then, of course, the strongest and usually the thickest portion of the colon, of the bowel, and in this case, the large bowel, are your circular and longitudinal muscle fibers. Now think about it. If this was cut longitudinally, and these are circular muscle fibers, so just think of the geometry. Probably most of the nuclei here are going to look round. So that's my hypothesis, and let's see if I'm right. Yeah, most of them look round. I guess I'm geometrically correct. Now, if the next layer is your longitudinal muscle fibers, you know, deeper in, then they should probably look spindly. And oh my God, they look spindly. So these cells are the same as these cells, but these are cut longitudinally with the cutting of the longitudinality of the bowel. And these are the circular or constrictive muscle fibers. Together, they get it. And of course, you may find some little nerve plexi in here, the myenteric Auerbach plexus, okay, which is a kind of the brain of the bowel because it does not require central nervous system innervation to do its job. Okay, now here's the next question. Now we have the loose or connective tissue again, the adventitia or serosa. How are we going to determine whether this is adventitia or serosa? Well, here's how we're going to do it. When you go to the very edge, whoa, look at all that fat. Of course, your bowel has a lot of fat around it too, especially large bowel. But if you see in these adipose cells now on the surface, whoa, I can't believe it. Let's see if we could zoom in a little bit better. Or zoom out is what I'm saying. Oh, we don't know because we don't see the surface. But if on the very surface of this fat you saw mesothelial cells, then this was probably a portion of the bowel that was intraperitoneal, like much of the transverse colon, and perhaps the very earliest part of the ascending colon, and then things like the sigmoid, for example. But the rest of the colon, the other half, would not have mesothelial lining because they would have an adventitia rather than a serosa, which is a visceral peritoneal mesothelial layer. But let's take another quick look because this really is the most normal bowel you'll ever see, large bowel. And we got the 1, 2, 3, 4 layers. So let's move on. And as long as we're dealing with normal things, let's also look at the appendix. And if you remember, in the entire gastrointestinal system, we always said that the muscular layer was the thickest layer. The exception to that is the appendix, Whereas the muscular layer may be the strongest layer, the thickest layer is always the submucosal lymphoid layer. Okay, so you're going to see some cells in here in the mucosa, but the thickest layer of the appendix is the submucosa, which has all of these secondary lymphoid follicles. And then you have a little bit of smooth muscle, mostly circular, but maybe a little bit longitudinal, because the appendix is the area where the longitudinal fibers of the colon, the taenia, always converge. So let's see if we could just give you a quick little view of the whole show. Mucosa, submucosal secondary lymphoid follicles, muscularis, some people call this muscularis propria, and then finally connective tissue. Most of the time the appendix is intraperitoneal, so you would suspect a mesothelial visceral peritoneal lining. But let me ask you a question. Let's say you saw a lot of neutrophils only in the mucosa. You think that's acute appendicitis? No, it could be an inflammatory process coming from higher up or even lower down in the GI system. Let's say you had a lot of neutrophils only in the submucosa, but not in the muscularis. Well, that could still be from an intraluminal acute inflammatory process. Hey, let's say that you had a lot of neutrophils here in the serosa, in this loose fatty tissue, but not in the muscular. Well, this could be from a peritoneal inflammation, an acute peritonitis, which is not caused by the appendix itself, but just involving the appendix. So that is why, in order to make the diagnosis correctly of acute appendicitis, you have to see neutrophils within these circular or longitudinal muscle layers. And you don't. You just see beautiful, smooth muscle cells, don't you? So let's go to the exit, and let's go to the rest of these colon cases. In fact, I wish I could find you the acute appendicitis case now, but I don't know where it is. We're going to be looking at these cases blind. Okay. Well, look it. We do have an acute appendicitis case because we have neutrophils completely infiltrating the wall of appendix here, going all the way from the mucosa to the serosa. And if you don't believe me, let's zoom in on high power. Here you go. Look at this. This entire muscular layer is not only loaded with neutrophils, but it almost looks like it's destroyed. It looked okay. And furthermore, not only does this acute inflammatory process extend into the fat, but also it actually forms little abscesses as well. Okay, so this is a periappendiceal abscess. This is at least a localized peritonitis, but remember, if this destructive process goes all the way through the appendix, it could cause a diffuse acute peritonitis, which is very, very serious. Most hot appendices, acute appendicitis, may show a lot of acute inflammation in the serosa, but it's localized. And at this point, you're probably saying, well, Minarsik is talking about all these neutrophils, but he hasn't proven to me that this wall of the appendix is destroyed by neutrophils. So that's why we have a high power. Look at 100% neutrophils totally destroying and infiltrating the remnants of these longitudinal smooth muscle fibers. This is a very serious appendix. The general rule is, if you have an acute appendicitis and you sit on it, in other words, you don't operate, the general rule is that it could and very often does perforate. And if it perforates to the point where it causes not just a localized peritonitis, but a diffuse peritonitis. The patient, usually a kid, could die. So much for acute destructive appendicitis with periapindal abscess and peritonitis. Next one. Also in the colon, or we'll call them bowel. I don't know if it's going to be small or large. Oh yeah, look. This is probably one of the most common things for a man or woman to have when a GI doctor does a colonoscopy. This is a little polyp, isn't it? And the polyp looks like it's about the same as the normal mucosal cells, but it also looks like has a increased thickness of normal mucosal cells. And in addition, with this increased thickness and hyperplasia, it may drag up a little bit of submucosa as well. And this is what we call probably one of the two most common types of polyps, a hyperplastic polyp. Well, two reasons that you know it's hyperplastic is that when you look at these glands, they are serrated. In other words, not only are they hyperplastic and needing an increased amount of submucosal predominance or submucosal protrusion, but they also are serrated, which means there's an increased number of cells. But the cells look normal. So if I was to show you these, there's a lot of goblet cells, there's a lot of lamina propria, but there's an increased amount of glandular hyperplasia. And then if we went to the normal mucosa, which is right next to it, which is going to be over here. Whoops, I'm not, yeah, you can see this. Looks exactly like this. So this is strictly a hyperplastic polyp. So polyps are not really true neoplasms, otherwise you'd have a single clone of cells rather than a mixture of cells. What I want to say is, if your doctor tells you you have a hyperplastic polyp and you ask them, what are the chances of that turning into cancer? His answer should be 0, because it's not even a true tumor to begin with. Okay, if your doctor tells you that a hyperplastic polyp could turn into cancer, then all he wants to do is make more money from you by having you come back more often so he could do more procedures. And you know what? I know a couple of guys that did that. I hope they're still not practicing medicine. In fact, I hope that they're in jail. So here we go. Here's the next case, which I don't know what it is, but we'll see. Oh, well, once again, all the way on the left, you see what I'm going to convince with you is a normal colonic mucosa. Okay, you can see the crypts. They're not really papillae. You can see the remnants of the muscularis mucosa. You can see some submucosal vessels. But the majority of what you see here is these long, elongated, papillary, or villous structures growing like grass, okay? Now, this is called a villous adenoma. And if you want to say that a villi is one of these finger-like projections, or if you want to call it a papilla, you can. They're the same word. But because of the geometric configuration of these glandular proliferations, they are generally regarded as growing faster than the other types of polyps. Because why? Because doesn't a grass grow faster than trees? When something is branched, it's generally growing faster than something that just sprouts out like grass, okay? This is a villous adenoma. It has a high likelihood of invading and turning into cancer, as opposed to a hyperplastic polyp, which has no chance of turning into cancer. Now, there are other polyps that are true neoplasms that are glandular, but the villus adenoma is the most dangerous of all. If it ain't cancer, you'll probably find a lot of atypia in the cells. But if it ain't cancer and you sit on it and do nothing, it will eventually become cancer. One of the most smartest surgeons I've ever met, he basically said, his name was Dr. Woodward, I'll never forget him. He said, you know, all those villus adenomas eventually turn into cancer. Why? Because they're growing straight out like grass. The ones that are, the next one I'll show you, the adenomatous polyp, does not grow as fast and has a much, much lower likelihood of turning into cancer. So maybe the next slide we'll see will be a tubular or adenomatous polyp. Let's see. Here is 4530. Well, once again, you can see it's bowel. And it looks like the mucosa of the bowel is now papillary. So maybe this is small bowel, okay? It has to be, because if you have villi in the gastrointestinal tract, it's not stomach, it's not colon, it has to be small bowel. But look, in the submucosa and even in the muscularis, you have these little clusters of what look like glands. So is this an adenocarcinoma? Well, most people would say it's probably malignant because it's invading the smooth muscle. So we don't care what the damn nuclei look like. This is something that invades smooth muscle, and it's in the small bowel. So why don't we call it adenocarcinoma? Well, I'll tell you why we don't call it adenocarcinoma. It's because small bowel almost never turns into adenocarcinoma. Yeah, you could probably Google a few case reports and everything. However, adenocarcinomas, primary adenocarcinomas, even if though they look like they're invading muscle, do not usually occur in the small bowel. Now, what if I tell you this patient also had flushing and diarrhea? Well, an excess of what hormone would give you flushing and diarrhea? Well, serotonin is a vasodilator. Serotonin also can cause diarrhea. So this is a tumor, a glandular tumor, and it's invasive, and you can call it a carcinoid. Why was it called carcinoid? Because it looks like a carcinoma, but it's a neuroendocrine tumor, not a glandular epithelial tumor. So these carcinoid tumors can occur anywhere in the lung, in the GI tract, stomach, blah, blah, blah. But most of them occur in the small bowel. And when does the patient usually get diarrhea and flushing? Well, not when it's just a small tumor, but very often when the patient has carcinoid syndrome, which is flushing and diarrhea, it's already metastasized to the liver. So it's a malignant carcinoid, but you'll never hear a pathologist say benign carcinoid or malignant carcinoid, because they are all regarded as potentially malignant. So if you ever ask a pathologist, is this carcinoid benign or malignant, he'll probably never answer you with a single word. He'll just give you a bunch of bullshit about how it's potentially malignant. Okay, sorry for using the bad word. Here's the next case. Once again, it looks like a colon. Once again, you could see mucosal lymphoid tissue. You could see a submucosa, which has some dilated blood vessels, but it's not really inflamed or hemorrhagic. You can see the wall, which is not infiltrated or inflamed or hemorrhagic. However, in the mucosa itself, if you just keep on looking, okay, you're going to see hemorrhagic areas like you see here. and you're going to see ulceration. This is ulcerative colitis. This is part of the spectrum of what we call inflammatory bowel disease. There's the hemorrhage, there's the ulceration. But you notice it's limited to the mucosa. It doesn't go too much into the submucosa, and it certainly doesn't go into the muscle. So this type of primary inflammatory bowel disease is not only limited to the mucosa, but it's limited to the colon. The other type of inflammatory bowel disease is not limited to the colon. It could occur in the small bowel, and perhaps even more commonly in the small bowel, or the stomach, or the esophagus, or even the mouth. Okay, that's Crohn's disease. But Crohn's disease has granulomas, and this is strictly ulcerative, inflamed mucosa. And they could be inflamed to the point where they're actually forming pseudopolyps, but you don't see that here. So here's an inflammatory bowel disease of chiefly of the mucosa and limited to the colon. And it does not dissect into the wall or the submucosa, usually. This is ulcerative colitis. However, in the process of this inflammatory and hemorrhagic process, and the higher turnover, the higher regenerative turnover of the glands, do you think this has a relationship to cancer? Of course, the answer is yes. Next case. Next one is 04770. Oh, and look. Looks like we have a bowel wall, or we'll say GI tract. But let's look to see if these are villi or pits. So let's actually zoom in on part of the normal mucosa here. Whoops, too much. And you could say, yeah, this is colon, okay, because these are pits. And when you look at the big picture, it looks like some of the mucosa and not so much of the muscular layer. And of course, the serosa pops out. This is a diverticulum. And it's very, very, very common disease. The one nice thing about it is that it's not associated with cancer. The bad thing is, however, is they could really cause massive inflammation in the wall. They could bleed. They could be fatal. They could obstruct your bowel. And listen to this. This is the most important thing. Clinically, surgically, radiologically, and pathologically, it could be very easily mistaken for cancer. But all it is are these so-called, even though they're called diverticulum, it's really a pseudo diverticulum because it's not the full thickness of the bowel that pops out. And basically, it pops out in the area where the muscularis is the weakest, which is where the perforating arteries from the mesenteric vessels usually go into the bowel. And this one is not inflamed. But let me ask you this. If technically it's connected with the lumen of the bowel, and a lot of the stool goes into here and stays there and doesn't get flushed out, then those so-called normal flora bacteria, by virtue of hanging out for weeks, months, years, could then cause a secondary inflammation. So not all normal flora are beneficial. Some of them are harmful if you don't keep flushing them out. So these diverticula are often impacted with feces, but this one isn't, and that's probably why it's not inflamed. So let's go to the next case. 4795. I think that the sirens are going to start pretty soon. Once again, big dilated submucosal blood vessels. You could see that instantly. In addition, this one looks like, because there's a lot of cellular reaction in some of these, it's not just blood. It could perhaps be thrombosed blood with organizing or acute thrombi. And let's see if we could prove that. Yep, that's the thrombus. And you want to find another one? Whoops, shouldn't have done that. Let's look at this one too. That might just be blood, but look, you're starting to get fibrin and organization. So these are thrombosed submucosal blood vessels. Could they be esophageal varices? Well, when you look at it, you have to consider that as a possibility. Another reason why you might think they're esophageal is because there's a squamous lining overhead. But actually, this is anus. This is the lower rectum. These are probably external hemorrhoids because they're covered with squamous mucosa, as opposed to internal hemorrhoids, which would be probably more likely to be covered with columnar mucosa. So there we go. Squamous, non-keratinizing, massively dilated vessels. These are hemorrhoids. Of course, because they're in the lower rectum or anus, they're probably more likely secondary to increased intra-abdominal pressure rather than portal hypertension, which you might be more likely to see in the upper portion of the rectum because that's fed by the portal blood vessels. In this part, you have non-portal veins. You have iliac veins and pudendal veins feeding this area. Okay. Let's exit it. And I don't hear the sirens yet, but look, we've done a whole bunch of it. So let's take our break now because it's already been over an hour. And we come back, we'll do 1, 2, 3, 4, 5, 6 more. And then maybe we'll do the 12 or so cases from the liver. And I'll feel like we had a good lab. So let's drop this down temporarily. Let's put up, well, not the ugly guy, let's put up the cute little guys over here. And, you know, my clock actually fell down twice last night. I don't think the hook was strong enough, but I think it's okay now. So let's play our 3 break songs, and we'll see in about 10 minutes. I think one of the break songs is long, so maybe it'll be 15 minutes. But believe me, we'll have plenty of time to finish this off. So let's start out with this one, but we will also put in 2 more.
Think of your fellow man, lend him a helping hand, put a little love in your heart. You see it's getting late, please don't hesitate. Put a little love in your heart, and the world will be a better place. And the world will be a better place for you and me. Here, just wait and see. Another day goes by, still the children cry. Put a little love in your heart. If we want the world to know, we won't let hatred grow. Put a little love in your heart, and the world will be a better place. All the world will be a better place for you and me. Here, just wait and see. Wait and see. Take a good look around, and if you're looking down, put a little love in your heart. I hope when you decide, kindness will be your guide. Put a little love in your heart, and the world will be a better place. And the world will be a better place for you and me. You just wait and see. People now, put a little love
yeah. She said I was the tiger she wanted to tame. Caribbean queen, now we're sharing the same dream, and our hearts they're beating one. No more love on the run. I lose my cool when she steps in the room. And I get so excited just from her perfume. Electric eyes that you can't ignore. And passion burns you like never before. I was in search of a good time, just running my game, yeah. Love was the furthest from my mind, yeah. Caribbean queen, now we're sharing the same dream. Don't want to stand our hearts, they're beating one. Ooh, no more love on the run. I moved. Caribbean queen, now we're sharing the same dream. Don't want to stand our hearts, they're beating one. Ooh, yeah. No more love on the run.
Unforgettable, that's what you are. Unforgettable, though near or far. Like a song of love that clings to me, how the thought of you does things to me. Never before has someone been more unforgettable in every way. And forevermore, that's how you'll stay. That's why, darling, it's incredible that someone so unforgettable thinks that I am unforgettable too. Unforgettable in every way, and forevermore, that's how you stay. That's why, darling, it's incredible that someone so unforgettable thinks that I am unforgettable too.
The sign that I flashed up twice already was extreme oldies. I love to play oldies. And I know that some of you are probably saying, why does that old guy, why doesn't he play good music? Why does he play that crappy old music? Well, let me tell you, you probably have your own ways of chilling out and being at your peak performance. And maybe it's music. And it is for me too. So this is my way of being in a good mood so I could do a good job, okay? And it's also a way for me to introduce you to when music was really, really good, you know, when I was a kid, because the crap that you're getting now is just lousy. So we're almost done. We just have a few more bowel cases, and then we're going to do a bunch of liver in the second half. And let's get going. How about if we go back to the slide box? And if you remember, we went to the intestine all the way up to, whoa, we got a few more here to do, don't we? Yeah, we got a few more. Let's start out with D32. Don't know what it is, but once again, I think we're at the point now where both you and I could just look at slides blind and form logical opinions rather than having a little label on it telling you what the answer is. This is the polyp. This is another, or the second, or perhaps first most common type of polyp in the colon. It is not a hyperplastic polyp, which is just hyperplasia of the mucosa. It is a true neoplasm. It's a true benign glandular neoplasm. However, even though I put this as my cover page for the whole GI block, because it's probably one of the most common types of polyps, I don't know if hyperplastic polyps or adenomatous polyps are the most common, but together, both of them, that's like about 90% of everything that your GI doctor might call a polyp. However, if you do look at portions of the glands in this glandular polyp, sometimes if you look long enough, I think you could probably imagine that some of these cells may be a little bit bigger or darker or atypical. So a little bit of atypia is a very common thing. However, most of the time, they never turn into cancer. Sometimes, we'll say a small percentage, they do. Now, most pathologists will tell you that percentage is low, okay? But most GI doctors will tell you that that percentage is not low. So when they tell you you have a adenomatous polyp, and sometimes they're also called tubular adenomas because the glands look like little tubes over here. They say, well, you know, these can turn into cancer. So rather than you coming back in 10 years for your follow-up colonoscopy, I think you should come back in 3 months so we could keep an eye on it. Well, that might be a little extreme, and I'm sure they have their literature to justify it. But still, classically, historically, the adenomatous polyps or the tubular adenomas, pretty much the same thing, are fairly low probability of developing into cancer, but they shouldn't just be totally ignored either. Now look at, do you notice that this submucosal stalk has nice blood vessels and nice connective tissue and nice muscularis mucosa? Okay, but let's say that you saw one of these slightly atypical glands maybe within here. Well, then you know you cannot call it a benign adenomatous polyp or benign tubular adenoma anymore, because even though this gland may look a little benign, it's invading the submucosa, so that makes it cancer. Okay, so that's the tip for the day. And let's go to the next guy, which is called K42. And looks like we got some type of GI tract again, don't we? And we have a bunch of inflammation throughout not only the mucosa, but the submucosa, and possibly even dissecting near or into the muscular wall. So this is an inflammation of a GI tract. This is probably large bowel, but it could be small bowel, okay? This is a deeper type of primary inflammatory bowel disease, deeper than ulcerative colitis. And this is called Crohn's colitis. Now, how do you prove that it's Crohn's colitis? I'll tell you how you can prove it. You can prove it because you can prove it because Crohn's colitis or Crohn's disease is also called granulomatous colitis. Okay, so let me ask you a question. What do you think that is? What do you think that is? I'm going to show you not only things which I will convince you are granulomas, but we'll even find some giant cells within them. Remember, in granulomas, you have clusters of macrophages surrounded by cuffing of lymphocytes. And look, there's a giant cell. There's a giant cell. So a lot of these are not quite as perfectly formed granulomas as you might see in tuberculosis. However, if you see a cluster of macrophages in association with probably even more lymphocytes, and in addition, you see these multi-nucleated giant cells, which are syncytial clusters of macrophages, like here, and maybe here, and probably here. You could call this granulomatous colitis. Now remember, Crohn's disease is not limited to the mucosa, and it's not limited to the colon, just like ulcerative is, okay? Ulcerative is limited to the mucosa and limited to the colon, but Crohn's disease can occur in the small bowel. One of the original names for it was terminal ileitis. Well, ileum is small bowel. It could occur in the stomach, it could occur in the esophagus, but usually it occurs in the small and large bowel. Classical Crohn's disease, granulomatous colitis. And does it also have a tendency to be more statistically associated with cancer? The answer is yes. Perhaps not as much as ulcerative colitis, but remember, any inflammatory bowel disease which is going to result in increased turnover of regenerative epithelium is going to be a risk factor for cancer, adenocarcinoma specifically. Next case, 022. Oh, look, another colon. You can see the crypts, you can see the muscle, you could see probably some type of neoplasm here because it's not organized like you see in the mucosa. So let's say that you and your buddies are taking a look at this and you're saying, well, look at, we got a bunch of glands, want to call it an adenomatous polyp, want to call it a tubular adenoma. And so you and your friends are fighting back and forth as to whether this is going to be a benign or malignant, or perhaps a adenoma with atypia, or maybe an early malignancy, or maybe not a malignancy at all. And then one of you jokers actually takes a look at this part of the cut, and you say, hey guys, you don't have to fight anymore as to whether this is cancer or not. We got a gland here that is completely surrounded and invading, like here. This is probably even a better one. We got a gland that's completely invading and disrupting and infiltrating these smooth muscle fibers. So you know this is cancer. So this is probably one of those polyps, perhaps years ago, now developing after generally years, although it could be quicker, into an infiltrating adenocarcinoma of the colon. Okay, how about 074? What do you think this is going to be? I don't know. Well, it's a colon again. Look, there's some mucosal glands. There's submucosa. There's an awful lot of inflammation. If you don't believe me, here, let's zoom in. Look at, these are a lot of inflammatory cells, a lot of neutrophils too, okay? And that extends, where we're looking at now is the submucosa. But you can also see it's extensively involving the mucosa as well. And not only that, but look, on the surface of the mucosa, you have lost your glandular architecture, and you have what looks like just fibrin and neutrophils. Well, what do you call something that's basically fibrin and neutrophils? You call it a scab, don't you? You might call it a membrane, because like a scab, it's a membrane, but it's not part of the normal colonic mucosa. It doesn't have glands, okay? So I'll tell you what, let's not call it a membrane. Let's call it a pseudomembrane, because that's what it is. This is pseudomembranous colitis. It's also generally called antibiotic-induced colitis, because when patients are on basically antibiotics, either wide spectrum or a long time, it kills a lot of their normal gut flora, and therefore the only ones that are not killed are the ones that are potentially resistant to the antibiotics, perhaps wide spectrum antibiotics, and they could do damage, okay? And the most likely bug historically to cause pseudomembranous or antibiotic-induced colitis is Clostridium difficile. Okay, everybody calls it C. diff in the hospital, C. diff. And there's a very, very easy, common, quick, effective test to see if you have the C. diff antigen in your blood. Probably antibody too, but the C. diff test is very widely available. Somebody comes in with the colitis, which could be severe or life-threatening, because look, it's really going deep. Perhaps it could even perforate the bowel, but more likely it just produces this thick scab pseudomembrane like you see down here. And there's a lot of innovative, novel treatments for this, including fecal therapy, but that's another story. Pseudomembranous colitis. Next one, a slide. I don't know what it is. Maybe it's a normal something or other. Let's see. Oh, yeah, it's another appendix. And remember, the appendix has a muscularis. It has a mucosa, which looks hemorrhagic and destroyed. It has a serosa, which looks inflamed. But mostly, we want to look at the muscularis, don't we? So let's take a nice full thickness slice all the way from the serosa. And look at, you have ulceration of the mucosa. We have a lot of inflammation in the submucosa. But look, do you remember when I showed you the normal appendix? I said there were no neutrophils in the muscularis. Well, look, there are probably more neutrophils in the muscularis than there are smooth muscle cells. So this is a slam dunk easy diagnosis of acute appendicitis. Case closed. I want you to take a visual memory picture of this. Neutrophils or polys infiltrating the smooth muscle fibers of the muscularis layer or muscularis propria of the appendix. End of case. Slam dunk easy diagnosis. Every pathologist has made it a zillion times. And by the way, if a surgeon goes in because he thinks there is an acute appendicitis and there are no neutrophils within there, then you could say, well, maybe the inflammation or the cause of the right lower quadrant pain and inflammation was something else. Well, guess what? That's okay, because it's better to go in for a normal appendix than ignore it and perhaps have it perforate and kill the patient, which are usually kids, by the way. Okay, normal colon again, over here on the right. We have a mucosa, we have a submucosa, we have a nice muscularis, we have a lot of nice fat. You don't know if this was intraperitoneal or retroperitoneal part of the large bowel. And you know it's a large bowel because, once again, these are pits. They are not papillae like you get in small bowels. So let's prove that just for a second here. See, the pits or the crypts of Lieberkühn. And look how nicely that little rim of muscularis mucosae delineates the mucosa from the submucosa. However, let's move on a little bit up further in the colon, like here. It doesn't look like these glands are as nicely as arranged. And I bet you, if we think that's cancer, we could prove it by showing that these glands have totally destroyed and disrupted the smooth muscle fibers. So once a GI cancer or adenocarcinoma invades, destroys, disrupts, infiltrates, perforates this muscularis mucosa and is now within the submucosa, like you see here, it is now a potentially metastasizable lesion. So if the cancer did not perforate the submucosa, the lymph nodes would probably never be positive. But once it's into that richly vascular submucosa loaded with lymphatics and veins, portal veins, arteries, then it could already be in the liver or at least the regional lymph nodes. And look, I didn't notice this before, but here's some lymphoid tissue or malt. Now this is an infiltrating adenocarcinoma. Where is the muscularis mucosa? Between the submucosa and the mucosa. It's not there. Why is it not there? Because this cancer has chewed all the way through it. Okay, next case. Or are we done? Yeah, we're done. We're done with colon. We have only one thing left in the second hour here, and there's not as many as there were, and that's going to be liver. So let's get rid of intestine, and we'll just stay with liver. And there's not as many as there were here. So how about if we just look at something that I might call liver normal 1? And instantly, without going into all the cells, you could see that basically the holes that you see here, both of these portal veins and or portal triads, which have both the artery and the vein and the bile ducts, they are regularly arranged and regularly surrounding the center portion of the lobule, which has no connective tissue. So I'm not even going to go into the sinusoids and the names of all the cells and the Kupffer cells. This is instantly, quick, take a picture with your eyeballs, a normal liver. Here, well, I will zoom in a little bit more. How about if we go, look at portal, 4 or 5 portal areas surrounding some central veins. So how about if we just zoom in on this area? Beautiful. The blood flowing from the portal vein through the sinusoids into the central veins. And the holes that have connective tissue are portal veins, and the holes that don't have connective tissue are central veins. And that occurs even on the gross level, because the central veins become hepatic veins, which have minimal connective tissue, and the portal veins are always very often accompanied by the artery here, and the vein here, and the bile duct here. And that's why they're called portal triads. Hepatic artery, portal vein, the biggest one, and then the bile duct. And you know, I should tell you something at this point. In toxic injuries to the liver, generally speaking, with some exceptions, the parts that are most damaged are the parts of the liver that are closest to the portal triad. Why? Because that's where the arterial blood comes in, okay? Now, the damages to the liver that are ischemic, however, like congestion due to heart failure, particularly right heart failure, the damage is usually centrolobular. So let's make this simple. Periportal necrosis, toxicity. Central lobular necrosis, ischemia. But there's a few exceptions to the rule. But that's easy to understand from a logical point of view. Here's another thing I called liver normal 2. And why did I do that? Because, you know, we said that the classical connective tissue in the liver is limited to the portal area, and specifically very well defined by the so-called limiting plate. That's the only place you should have fibroblasts. But the rest of the liver, the connective tissue of the liver, is supplied not by fibroblasts or collagen fibers, but by these very delicate reticulin fibers, just like in a lymph node or a bone marrow. So these are reticulin fibers in the portal area. There's the artery, there's the vein, there's the bile duct. But these reticulin fibers are also in the around the sinusoids and in the central vein areas. And remember, this area here is very well delineated. There's a few fibroblasts here, but they should stay within the limiting plate. Once there's a destructive process, these fibroblasts can actually join up with other portal areas and eventually form nodules. And you know what that's called? That's called cirrhosis, no matter what the causes are. So there's one I called liver normal 3, and I don't know why I did that, but let's look. Yeah, just another perfectly normal liver. Portal areas. Without much imagination, you could imagine that these holes follow more or less a hexagonal pattern, and the areas between the hexagons might be called lobules, and specifically an area between two portal areas in the central vein might be called an acinus. And the flow of blood is from the portal veins to the central veins. Okay, let's go to the next one, which is going to be a bunch of cases. And folks, we're not going to make this long. These are all cirrhosis. I'm going to show you the many phases of cirrhosis. Now remember, cirrhosis can be called by toxins, of which alcohol is thing. If you have a hepatitis, okay, if you have iron overload or excessive iron destroying the liver, if you have an excessive problem with copper metabolism, Wilson's disease, the lobules become nodules. The nodules can be large, what they call macronodular, or they could be small. Or the cirrhosis could be classified by by what caused it, like alcoholic cirrhosis, post-hepatic cirrhosis, post-necrotic cirrhosis. But I don't want to confuse you. I just want to show you that all 6 of these cases have only 2 things: nodules and fibrosis. And here's the first one. Okay, look at all that fibrosis, fibrous tissue here, here, here. If you don't believe it, and you did a trichrome stain, these would be green, wouldn't they? And most of these nodules are not much bigger than the so-called liver lobules, so you might want to call it micronodular cirrhosis, but that's just an adjective, okay? Even though certain types of cirrhosis, like alcoholic cirrhosis or Lennox cirrhosis, are micronodular, they're probably better just termed alcoholic cirrhosis. And some of these nodules are a little bit bigger as well. So, okay, cirrhosis number 1. 4006 will be cirrhosis number 2. Oh, look at these beautiful nodules. And some of them are a little bit bigger than others. And look at, there's a big one. You might call it a macronodule. Here's a small one. You might call it a micronodular. So this is nodules and fibrosis. How am I going to prove it to you? By zooming in. Here's a nodule, here's a nodule, here's a nodule, here's a nodule. Notice, these are not acini, these are not portal. And here's the fibrosis between the nodules. And even though they might not look, they might look the same color as the hepatocytes. If you stain this with a connective tissue stain that stains collagen green, remember collagen should only be a little bit limited to the limiting plate, then you know that this is the most classical type of cirrhosis that you'll ever see. But here, let's show you a few other ones anyway. B127. Well, what can we say here? It looks like there's a lot of fibrosis. It's kind of hard to see the nodules, but maybe that's one. And I'm getting a little nervous because I can't even remember what this was labeled as, but maybe if we zoom in, I could figure it out. Oh yeah, look at that. A lot of these lobules look like they have in the cells granules, okay? And look at some of these granules. Oh, I wish I could find a better one for you. Let's find some classical granules. Some of these granules, like you see here, look like they might be hemosiderin granules. This happens to be a cirrhosis that was caused by iron overload or hemochromatosis. Usually in the liver, the iron should be limited to the macrophages. But in this one, it actually involves and destroys the actual hepatocytes, and that makes it hemochromatosis, and eventually that causes a cirrhosis. And most of it is hereditary. Okay, look at, see all these little granules? If you did an iron stain all of these little granules you see within the cytoplasm, which are tiny, would be green or blue if you did the Prussian blue stain. And by the way, do you notice how in these regenerating nodules, some of the nuclei are bigger and darker? Well, as you know, hepatomas almost always arise in a previously existing cirrhosis. So not only does this patient have cirrhosis, which is a fatal disease, but he could be developing another fatal disease called hepatocellular carcinoma as well. Although most of the hepatocellular carcinomas usually develop from hepatitis cirrhosis, post-hepatic cirrhosis, but any type of cirrhosis. Okay, here's another one. Oh my God. Here's some more cirrhosis. And all I could say, here, let's take a better look here. Once again, you're looking at a lot of things here that look like they might be little glands as well. Maybe these are remnants of bile ducts. Now, why would you have so many bile ducts throughout the liver? Because the liver parenchyma itself has collapsed. This could be the beginning or part of the spectrum of what they call a fulminant cirrhosis. And fulminant cirrhosis occurs more often in hepatitis B. And the reason why these look like these are little glands is because the lobules have collapsed. And this is the most common cause of death in acute hepatitis, is collapsed. There is nobody that's ever survived a collapsed fulminant hepatitis where the lobules are collapsed. How about if we go down to the last two? These are all cirrhosis, folks. I chose a whole bunch of different things. This is another classical cirrhosis. The pinkish orange things are nodules. They're not lobules, they're nodules. Some of them are a little bigger than others. And look at all the fibrous tissue and even lymphocytes between the nodules. So once again, you know, when I was teaching in classrooms before I got wise and decided to do everything at home, I always made the students stand up during this part of the lecture or this part of the lab. And I made them recite two things. And one of them was, cirrhosis is two things. It's nodules and it's fibrous tissue. And look, and the most, if the picture is predominantly fibrous tissue, then that fibrous tissue, like all scars in fibrous tissue, is going to contract. That's why in the late stages of the cirrhosis, the liver could be smaller than usual. In the early stages, where there may be a lot of edema, the liver may be bigger than normal. But the main explanation for hepatomicroly, or small liver, is cirrhosis. And those are usually nodules as well. If you could feel the nodules easily with your hands, with a blindfold on, it's probably macronodular. If you have to use a magnifying glass to see the nodules, because they're not much bigger than lobules, that's probably micronodular. And that's why GI doctors, when they come to see autopsies in livers, they always bring a magnifying glass. Last case, maybe an early cirrhosis. Why? Because you might start to see the beginning of nodules, but what you really do see is fibrosis, or what they call bridging fibrosis between one portal area to another. And eventually, as this fibrosis progresses, they then convert the lobules, or groups of lobules, into nodules. So you want to call this early cirrhosis? Sure, let's call it early cirrhosis. And see that little bunch of fibrous tissue extending from the portal tract? Eventually it'll connect up with another portal area. And bridging fibrosis is the early stage of cirrhosis. Okay, we're done with the cirrhosis spectrum. Let's go into, whoa. Did we look at some of these other things? We saw the normals, we saw the cirrhosis. So we've got about 9 or 10 more slides. I know we're showing you a lot of slides today, and you really have to pay attention because I think all together, oh, well, look, here's another liver. I guess you could believe it. But it doesn't look like the sinusoids are too open. And why is that? Well, it looks like it's pretty firmer or more solid than it should be. Oh my God, well look. Not only do you have remnants of these sinusoids, but you got this pink eosinophilic amorphous material completely filling up the liver. Maybe the liver weighing normally 1,500 grams, maybe this weighed 3,000 grams. What is the differential diagnosis for amorphous, glassy hyaline deposits throughout the liver? It's amyloidosis, okay? Basically remnants usually of immune protein buildup, seen very often where you've had buildup of immunoglobulins like multiple myeloma and chronic granulomatous disease. Classical amyloidosis of the liver. Next case. Does it look like a cirrhosis? I don't know, but if you look at these portal areas like here and here and here and here, they are surrounded by a whopping amount of inflammatory cells. That's because the primary area of inflammation is not exactly the lobules, but it's these portal biliary ducts. This is a biliary tract infection, cholangitis. It could be autoimmune, what they call primary biliary, eventually leading to primary biliary cirrhosis, or it could be secondary to ascending bacterial infections from the GI tract. Think of it as maybe, reverse flow of bile, for example. So this is a cholangitis. And let me ask you a question. If you think most of these cells surrounding this bile duct are lymphocytes, you could call it chronic. If you think a lot of them are neutrophils, you could call it acute. How do you like that? I think this is mostly a chronic cholangitis. But eventually, like all serious diffuse diseases to the liver, could wind up being a cirrhosis. And they call this type of cirrhosis biliary cirrhosis. And if it's not due to cholangitis, they would call it primary biliary cirrhosis, which is an autoimmune disease. But if it's secondary to a bacterial cholangitis, then it would be called secondary. Okay, am I talking too much? Please don't answer that question. Well, once again, we got 1, 2, 3, 4, 5, 6 or 7 portal areas, and it looks like maybe there's some increase in these dark peppered inflammatory cells around them. So this is not an easy case, but there are a lot of non-specific things that could inflame chronically with lymphocytes, portal areas, but early hepatitis, viral hepatitis, classical viral hepatitis, whether it's A, B, C, D, E, would be one of them. And remember, I said that in early hepatitis, the chief area of inflammation is around portal areas, but as it progresses, it could involve these lymphocytic infiltrates throughout the sinusoids as well. And also remember, even though it's called acute hepatitis, the chief cell of this acute hepatitis is not the neutrophil, but it's these lymphocytes. So it's another example of something that's acute clinically, but chronic inflammatory cells pathologically. There's a lot of exceptions to that rule, like, for example, encephalitis, for example, is another good example. Or many viral acute inflammations are characterized by lymphocytic infiltrates rather than neutrophils. 4634. Oh my God, another liver. And look how red most of it is. Well, is that amyloid? No, it's not amyloid. It's blood. Okay, this is a liver, probably the most common type of liver disease that could lead to cirrhosis. This is chronic passive congestion due to heart failure. If your heart fails, or more specifically, your right heart, the blood backs up because it can't pump out the venous return that's given to it. And it backs up into the liver. And remember, it's ischemic, so it affects the central portion of the lobule. And the central portions of the lobule can then become necrotic because they're not getting enough blood. So this is chronic congestive heart failure. And in addition, as the congestion gets worse, you could also have the development of fibrosis and cirrhosis. So isn't that interesting? You can have cirrhosis or liver failure secondary to heart failure. Okay, chronic congestive heart failure. Okay, so much for that one. Let's see what else we got here. It's a gallbladder. And the gallbladder is edematous. And there's hemorrhage in it. But look, when you look at the mucosa of the gallbladder, we have the columnar lining, but we had a lot of chronic inflammatory cells infiltrating the muscular layer and the wall. So this is chronic cholecystitis. Okay, if these cells in the mucosa and wall were neutrophils, you might call it acute cholecystitis. It's that simple. Here's another one. Another liver, and it also looks like it's congested. And this is even a better example because look, you can see that the general hexagonal architecture of the liver is preserved. So these are not nodules. However, the central portion of the lobule, which we're going to see here, is necrotic. And this is another case of central lobular necrosis secondary to chronic, we'll say, left-sided congestive heart failure. Okay, and not only is it chronic necrotic, but this blood has broken down and can actually be chewed up by the Kupffer cells or macrophages that are in the liver. So there'll probably be increased iron or hemosiderin in this as well if you did a Prussian blue hemosiderin stain. Okay, hey, we're near the end. Only what, 4 more left. Let's do them quick because I don't want to keep you more than the 2 hours. Let's make this easy. Forget about the thing on the top. This is just going to be a squamous cell carcinoma of the esophagus. Here, you don't believe me? Well, let's look at it. Okay, you could see that we have these little nests of clusters of cells. They're not glands, but they look like they're squamous cells, and they're infiltrating the wall of the esophagus. Okay, classical squamous cell nest. Fairly well differentiated, but look, what else has it done? it has also metastasized to the liver, because up here you can see remnants of liver, not totally normal, but this whole big ball underneath it, once again, are squamous cells. Don't they look like squamous cells? Can't you see like little bridges between the cells? So this is metastatic squamous cell carcinoma to the liver. What portal organ might metastasize squamous carcinoma to the liver? Probably the lower esophagus, right? Because that's portal drained, isn't it? But it could be anything. It could be lung. It could be any squamous cell carcinoma anywhere. It could be cervix, esophagus, oral cavity. Okay, let's go on to the last three cases. Whoa, another gallbladder. You could see, however, the wall is disrupted with the hemorrhagic process. And in addition, the mucosa, and really the whole wall, is just loaded with some lymphocytes, but mostly, I think you'll agree, these are all neutrophils. If you look closely, they are lobulated cells with plenty of cytoplasm. They're not mononucleated cells that have minimal cytoplasm. And here we'll prove that to you right now. These are all neutrophils. Acute cholecystitis. Okay, could the gallbladder perforate because of this acutely destructive process and cause a peritonitis and even death? Of course it can. Second to the last case. Ooh, looks like it's another liver. And what can we say? Well, we could say most of the liver looks kind of white rather than pink. So why would that be? Well, because these lobules, these white lobules, are fat. And this was labeled as fatty change, or some people call it fatty infiltration, or some people call it fatty metamorphosis, or some people just call it steatosis of the liver. This is a liver that perhaps more than half of its weight is fat. Could this person have been an alcoholic? Could this person have been a diabetic? Or could this person just have been massively obese? Because those are the three main differential diagnoses of fatty liver. Now, could it be that this person has been a drinker and has perhaps some inflammatory changes in the liver, which eventually are associated with a lot of fat, what they call alcoholic hepatitis? Can an alcoholic hepatitis go into cirrhosis? Of course it can. Any hepatitis can go into cirrhosis. And finally, let me ask you this question. If this liver weighed 2,000 grams, which is a little enlarged, or let's say 3,000 grams, what percentage of the weight of the liver do you think is fat? I would say at least half, maybe 60-70%, because that's what most of the cells are. The fat globules that are bigger than the cells are called macrovesicular fat. The fat that is generally within the cytoplasm of the cells, like you might see here, is called microvesicular fat. And these big lobules here are macrovesicular fat because they're bigger than the cells. Last case, I'm glad to say we're right at the 2-hour point here, so I betrayed you again, made you go the full hours. I don't know what this last case is. Let's see what it is. It's probably going to be a liver case. Oh, it's a gallbladder case. Yeah, look. We don't see much by way of inflammation of the wall, acute or chronic. You could probably see a nice little layer of mesothelial cells here because most of the gallbladder But what do you see in the mucosa of these little papillary projections of the gallbladder? Well, you see clear areas, don't you? And you also see that these clear areas are clear, like anything would be clear. It's because there's a lot of fat in there. And look, these little macrophages, foamy macrophages, are just loaded with fat. This is cholesterolosis of the gallbladder, and this is the most likely thing to give rise to the cholesterol gallstones. Okay, cholesterolosis of the gallbladder. So if these things became stones, they'd be yellow because of cholesterol and not necessarily green or black because of bile. Hey folks, we're done. I hope you enjoyed it. We're exactly 1 minute late. So let's play our final song. And I'm tired, and probably you're tired too. So let's call it a day. We'll say rock on. And the last song is going to be something you don't have to listen to, but it's one of my favorite songs. It's by The Doors. It's called Light My Fire, their signature song.
That it would be untrue. You know that I would be a liar if I was to say to you, girl, we couldn't get much higher. Come on, baby, light my fire. Come on, baby, light my fire. Try to set the night on fire. The time to hesitate is through. No time to wallow in the mire. Try now, we can only lose, and our love become a funeral pyre. Come on, baby, light my fire. Come on, baby, light my fire. Try to set the night on fire. meditate is through. No time to wallow in the mire. Try now, we can only lose, and our love become a funeral pyre. Come on, baby, light my fire. Come on, baby, light my fire. Try to set the night on fire. You know that it will be untrue. You know that I would be a liar if I was to say to you, girl, we couldn't get much higher. Come on, baby, light my fire. Come on, baby, light my fire. Try to set the night on 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 fire.
Well, that was the immortal Jim Morrison of the Doors giving you some very, very good advice. And I hope that in the very near future, or even today, you actually do light somebody's fire. Next block, next week, in 5 days, will be called SMS, for skin, muscle, and skeleton, and joint. So it's going to be another maybe 4 or 5 block. But until then, buzzards, go out and light somebody's fire.